Hello, everybody. My name is Valeria Ferrari. Thank you for being here. It's a big pleasure for me today introducing a new webinar, an important webinar with Dr. Riaz Yar. And I'm going to spend a few words about Dr. Riaz, and then, of course, I will leave the word to this amazing presentation. So Dr. Riaz Yar graduated from University of Liverpool and is running his own practice from 2003 before gaining the MFDS from the Royal College of Surgeons in Edinburgh. And Dr. Yar also completed a master in restorative dentistry, and in 2011 completed a 4-year-long monospecialty training in prosthodontics at the University of Manchester. And as well as completing the specialty prosthodontic training, Dr. Riaz has undertaken a diploma in postgraduate dental studies with the University of Bristol, and a diploma in implant dentistry with the Royal College of Surgeons, again in Edinburgh. Dr. Yars has also most recently completed his master in soft tissues around implants and teeth with Professor Zucchelli in Bologna, and completed his PG certification in education. He's also visiting professor in prosthodontics at College of Medicine and Dentistry in Birmingham, Ulster University. And his main topic of interest is TMD, so TM joint disorder, and also occlusion. You will see the perfect integration of different technology for a better analysis of the patient, and also how to evaluate all the data and integrate all the data that you can obtain with the new technology for having the best treatment for your treatment. So thank you again for being here. It's a really big pleasure. Thank you, Dr. Riaz. It's really, for me, it's so important. And please, if you have any questions, just write them in the Q&A section. I will read it at the end for not disturbing the doctor while he's doing the presentation. So thank you.
Thank you very much. Thank you. Thank you, Valerie, and thank you, Teethan, for asking me to talk. So, you know, when I started dentistry, I had a picture. I wanted to imagine being able to rehabilitate our patients so that we know we've made a difference. And the difference aesthetically for me is quite straightforward. You know, you show them a mock-up and you show them a smile, and if they like it, you deliver it. It's more predictable. But how do we know that we actually improved the function of the patients? How do we know that we actually truly rehabilitated the patients? And so when we sort of look at a checklist for our patients, this was very typically what we would do. We would have a facial analysis, healthy TMJ and muscle assessment, aesthetic analysis, a functional analysis, and I'll talk more about that as we go through. And then if we're reorganizing the occlusion, we would use Centric Relation as our reference point because the teeth were not a reproducible point. Already Valeria has introduced me, so I will leave this slide to itself. So the way I look at the whole system, I need to make sure, for me to be able to deliver comprehensive restorative care, we need to understand every element of the jigsaw piece. So first thing we start out is perception of teeth. You know, how does the patient perceive their occlusion and how sensitive are they? So what we know from the literature, and you'll see that there's quite a few papers, reference points there for you, that periodontal mechanoreceptors can sense between 8 to 60 microns. Why is there a difference between humans? Because of their tension, because of their neural signature. Everyone is slightly different. Some people are very sensitive, some people are less sensitive. So what we know with chewing, for example, when our patients chew, the sensitivity reduces. It has to, otherwise you would always be eating very slowly because you would be super aware. So the awareness of the cortex in the brain, that reduces through descending inhibition our ability to sense things. We still can sense hard foods and things like that, but it can't be as sensitive as 8 microns, otherwise we would sense every little thing. So occlusal perception is important, but that is in a long axis through the tooth, where the periodontal mechanoreceptors. But what about labial or buccal or interdental mesial distal? There's also perception interdentally, and that is between 40 to 30 microns. But then we need to relate that to function. So if we look at Svensson and Gregorius's paper, what we realize is that teeth are very important for function. That periodontal mechanoreceptors, if we look at this paper, he is biting, the first example is he's biting into a nut, and look at how smooth the movement is. But look what happens when they do a bridge. So the patient is now biting into the nut with Phonetics. Look at how the movement narrows, becomes protective. It is a protective mechanism. And then look at implants. Look at how irregular the movement is, but look at how the nut is broken down. So keeping teeth for me is obviously going to be the most harmonious way in rehabilitating our patients and keeping muscle harmony. But we still need to rehabilitate our patients if they don't have teeth. When we look at adaptation for our patients, how do they adapt then to your occlusion? There are some literature models out there, for example, Roy's adaptation model, and he talks about adaptation not just being physical, it is also psychosocial. So we need to understand our patients more than just them being a human that walks in and is having dentistry. They are more than just teeth. So then what is an ideal occlusion? Is it an ideal occlusion because we use an articulator? Because we give canine guidance? Is that truly physiologically correct for our patients? How do we know if we don't measure it? So if you do some work, how do you know that you've made a difference? You need to be able to measure it. The patient telling you it feels good is not reliable, because if their perception is in the, rather than 8 to 60 microns, it's 50 micron perception, then your occlusion isn't right. Because humans are very plastic. The neuroplasticity of the human is great. And so when we increase the OVD of the patient, we are testing their adaptation. We are testing how plastic they are. Kleinberg said that, if you introduce something, that is a true test of a patient's adaptation. So if you introduce an interference, this will tell you how adaptable the patient is. So we say the majority of cases result in positive adaptation. But how do you know if you haven't measured it? And that's what today is about. It's about using the equipment to measure our patients at the start of their treatment and also at the end of their treatment to see whether we really had a positive adaptation. And this is, for me, is very important, because the brain is a very complex organ, and it's an organ that allows us to adapt and become plastic and allows us to learn new motor skills. For example, you lose a tooth on the left side, the patient starts eating on the right side, they have pain on the right side, they start eating on the left side. They can learn new motor skills when presented with problems. But the risk is that if you don't provide precision in your occlusion, some of your patients may develop something called occlusal dysesthesia. And another term for this is occlusal hypervigilance. They become more sensitive and more aware of their bite. And then they're always trying to search for this comfortable occlusion that now does not exist. It exists in their mind, but now doesn't exist because the teeth have moved, have changed. We'll never find this place again. Because everybody has their own neuro signature. It is a self-knowledge, a self-interpretation of their own bite. And if we change it, we risk them developing occlusal dysesthesia. So we have to spend time not just restoring our patients, but ultimately rehabilitating our patients. Because this is what we would do when we needed to replace an arm, a leg. It was an aesthetic replacement of the limb, but it wasn't a functional replacement. It allowed them to function aesthetically. People looked like he looked like he had an arm, he had a leg. But what about function? They couldn't use it. But now with targeted muscle reinnervation, we're able to rehabilitate these patients. They are aesthetic as well as functional. Up until this point, I was restoring the teeth using mechanical and analog devices. Now we want to rehabilitate our patients. So I use the Teethan for my muscle data, and I'll talk why I enjoy the Teethan more than others, because for me it is simple. It gives me the data that I need. It doesn't overcomplicate it for me, as long as you understand what the parameters are and what it's telling you. I use the module to look at functional data. And I use T-scan to look at dental data, teeth force. So I want to know the occlusal force of my restoration. Are these proud? Have I done something wrong? Have I created occlusal imprecision? Because they are all interlinked. So what I've been doing for the last couple of years, I feel more comfortable about rehabilitation. In the past, I was restoring the patient. I was providing an occlusal scheme that was driven by the articulator. It was easier for me to give a protrusive check record to try and calibrate the horizontal condylar inclination, but that was nothing like the TMJ anatomy. The TMJ anatomy is like a potato. It's not like a ball. It looks nothing like the same. You have different joint spaces. The movements are different. So what we have to recognize is that when we restore, the reason why we give disclusion is because it's easier to do. That is the real reason. Yes, the muscle activity reduces and so on, but I don't need muscle activity reduction. I want muscle harmony, muscle function, not muscle dysfunction. We use reference planes like Frankfurt plane. It was created because we wanted to put the horizontal plane in the human. So when we did that, the articulator is also parallel to the floor. So we have this value. This is not used by a neurologist or a neurosurgeon. He does not use Frankfurt's plane because it doesn't exist. It only exists in dentistry. So what we really want to know is, do we restore or do we rehabilitate our patients? That is the key. So when we look at the occlusal scheme for rehabilitation, what we want to make sure is that we're improving the existing chewing cycle. That's number one. Combined with that, that gives us muscle health. This has to be related to a balanced centric occlusion. So there is maximum contacts in centric occlusion or maximum intercuspation or ICP, whichever term you like, because we need to fulfill the objectives of the system. We need to maintain health or improve it. But if you can't measure it at the start, how do you know? So this is how the system works. When teeth touch like this, through chewing, through swallowing, there's an impulse in the periodontal mechanoreceptors. This goes up through the ascending pathways into the brainstem and into the pons and medulla oblongata. Why? Because within that is the central pattern generators. Central pattern generators, they also exist for your walking, for going to the bathroom, for respiration, for breathing. So we don't think about chewing or swallowing unless there is a nociceptive reflex, or we have pain or we have dysfunction. Then we start to become aware of our chewing. This information goes to the muscles. So you know that when you eat soup, you don't chew hard. You know that if you have a nut, you have to apply a bit more force. This information comes via the periodontal mechanoreceptors, and the muscles are what generate the force to break the food down. But if you bite on something hard, like a nut, then you have a reflex arc. And information goes to the higher brain, the somatosensory cortex, the cerebral cortex, and we learn about food. So the first time you had, I remember I was talking to Valeria, and I was in Bologna, and the first time I had a cappuccino ginseng, the taste was amazing. What did I learn from that experience? That I'm going to repeat it. But I also remember the time I had snails. I didn't like the taste. So I learned that I'm not going to have that again. So we call this feed forward learning, as well as feedback. So this is the system that you've been taught about both at undergraduate, postgraduate level. And there are 5 main jobs for teeth. Three are physiological and 2 are pathological. So the main jobs for teeth are chewing, swallowing, and phonetics. That's its main function. Obviously, there's a deeper function to it. You break food down, you have greater nutrition, you have greater health. And we'll talk about why mastication is so important later on. But then when we have patients who parafunction, so bruxism and clenching, or hypernormal function, such as habits, biting their nails, chewing gum, these are all things that can put more duress on the teeth. So when we come to assess our patients, we ask our patients to chew. So when we ask them to slide their teeth left and right, you do this because you are trying to replicate chewing contacts. When you ask them to tap their teeth together, you are doing this because this is their swallowing position, their swallowing contacts. I look at phonetics as well, especially in the incisor region, because these are important articulators. And even more important, if we have a patient who parafunctions and they are a clencher, we want to have good static contacts, good dynamic contacts if they block, otherwise they will destroy your restoration. So this is the system. And you see that the patient is chewing the food. This is all about muscle harmony as well as dental harmony. So tooth harmony, and then look what happens. As they swallow, it is a peristaltic wave of muscle contractions. About 35 to 37 muscles work through mastication. Look at the teeth, how they come together when he swallows. So ICP is a swallowing position. The tongue is something that we tend to forget, and it's quite an important muscle, especially when it comes to swallowing. So if we are going to treat our patients, we need to start with an assessment of the TMJ. Why? Because this is the first part, extraoral examination. The drivers for your teeth are your joints and muscles. So we need to be assessing their health before we start any complex rehabilitative work. If we use a class 3 lever system as an example, a nutcracker, the fulcrum is the TMJ joint, the muscles are the driver, and you put the nut always closest to the fulcrum. Why? Because the effort required to generate the forces is less. If you put the nut further forward or away from the fulcrum, you have to put more effort to generate the forces. It's why the incisors incise, bring the food in, and the premolars, molars break it down so that we can then digest the food. So this system is attached to the brain, and we talked about human adaptability. And the things that affect human adaptability are things like stress. Cortisol hormones in the system have different effects on different people. For example, when I'm stressed, I eat more. But a friend of mine, when he's stressed, he eats less. So cortisol has a different effect on each individual. Illness has an effect on our adaptation. Age, you have genetic variation, because TMD is a complex system. We have to understand a lot about our patients to be able to treat temporomandibular disorders. And one of the diagnoses within this is masticatory myalgia, so muscle mastication inflammation, or myofascial, the facial muscles of expression, as well as the muscles of mastication. It's all linked, but symptoms don't occur through people's life constantly. It goes up and down when we're stressed, when we're losing our job, when the children are ill, when you're having an argument with your partner. So these are all different periods of stress, and our adaptation is affected by that. And sometimes our pain also increases. And patients tend to wake up with strong pain in their jaws, but there's a psychological impact to the chronic pain. And what is important about chronic pain is that the longer they have the pain, the more sensitized they become to the pain. It is not the opposite. Some people would think that the longer you have the pain, you will get used to it. It's not like that. It's you become more sensitive to the pain. So then they start to become down and depressed. And this was the case that I did 5 or 6 years ago. So we did an upper arch and a lower posterior rehabilitation. These are the static and dynamic occlusal contacts at the time of fitting the restorations. And then I didn't see her again for a couple of years. She comes back. This is 4 years later. So everything is still looking good. But the occlusion has changed because she has some muscle pain. She has myofascial pain and her static and dynamic contacts have changed. Why have they changed? Well, these are zirconia restorations, so they're not going to wear that much. But her muscles have changed, and therefore her jaw position has changed, and therefore her occlusal contacts have changed. Because the system is linked. We have to treat the whole human. And also there's a link between stress and the stomach and sleep. If we don't eat well, we don't sleep well. Some people grind more. Is it because of the fact that they haven't eaten well? We also have to be able to assess cervical positioning, postural positioning. We also need to understand the system, because some patients with Hashimoto's can develop TMD, small fiber neuropathy, which is a very specific field within TMD. But even young people can get reactive arthritis due to chlamydia. So TMD is a very complex system. But what we need to start out with our patients is a detailed analysis. This is an aesthetic analysis because that's what the patient wants. We do a functional analysis, which is a static one first: centric relation, skeletal incisal molar relationships, occlusal plane, phonetics. And then we look at muscle data. So I use Teethan for muscle data. I use T-scan for teeth data. And then I use the module for functional data. So far, when we look at centric relation, because this is our position of restoration, there's classically 4 schools of thought. You have the neuromuscular school, you have the uppermost school, the superior school, and the most rearmost school, and then you have CR, which is superior anterior school. So they all have a different rationale behind it. So which position is correct? Is the neuromuscular school correct? Is the anterior superior position, the most retruded position, correct? Is the neuromuscular position correct? Does that mean that if we don't put all our patients into centric relation, our patients are sick? How do you know that you're in centric relation? Do you take a CBCT? Do you take an MRI scan after you place them into centric relation? So we need to be sensible about what is a physiologically correct position. For me, it is a musculoskeletal position and therefore anterior superior. What determines this position? What determines it for us is the muscles. We need to look at the muscles because that is what closes the mandible. That is what seats the condyle in the glenoid fossa. Nothing else. The muscles. And if we use Marcel Legal's work and Roger Yerger, and I always comment about Marcel Legal. He passed away last year, but he left a lasting mark on me and taught me, certainly opened my eyes to understanding occlusion at a different level. And he's not with us anymore, but I miss him dearly. And if we look at Ackland's paper here, what he did was he looked at the force vectors when you are replacing a TMJ joint with a metal prosthesis, because you're going to have to make sure that the forces on that prosthesis are balanced. So they used a musculoskeletal modeling system. And we realized that each of these muscles have a force vector that are predominantly anterior superior. Masseter, a very large muscle, has superficial and deep fibers. And when we close, this is an elevator muscle, it helps seat us superior anterior. Temporalis, the vector force is mainly superior, but the horizontal fibers also have a slight anterior component to it, but the predominant force is superior. And then we have the medial pterygoids, which also have an anterior superior vector force. Look at the muscle angulation. The muscle angulation, the muscle fiber orientation tells you that it's logical that everything has a slight anterior stroke superior force. So I use physiology, and the lateral pterygoid muscle force is predominantly anterior. So we get a harmony when all the muscles together end up resulting in an anterior superior positioning. So we need to make sure that the muscle health is important. How I record centric relation, I use two techniques, but classically now it's more leaf gauge. So we can get the patient to open, bite on the leaf gauge like this. We ask them to move forward and backwards, and then we ask them to clench. And that clenching process closes the space. And we find our first tooth contact. So when do we use centric relation? We use it when their existing tooth position is failed. And that is a big topic in itself. It can be failed due to tooth wear. It can be failed due to muscle disharmony, such as temporomandibular disorders. So we need to reorganize or rebuild their teeth. So up until now, we've been forcing the human to fit the articulator. So now it's changed because we have the tools. We want to rehabilitate our patients. That is the key objective. How can we rehabilitate? Well, one of the main jobs of teeth is mastication. So we need to understand that process. We need to understand what normal shapes or muscle health looks like when the teeth are breaking the food down, because it is the whole system is affected by it. If you don't break your food down properly, you end up with acid reflux. Why? Because your clump size is too big. So the stomach has to produce more acid to break it down. So there is an effect. It may not be straight away, but it is a cumulative effect. And there's a lot of studies growing now that show that mastication, if not harmonious, can lead to an increase in food intake because we're not getting full. It can lead to other health issues. So we need to make sure we're getting our patients to chew their food properly. And if you look at teeth, they are designed to break the food down. They have a good occlusal table. They have cuspal inclines. So they are like points designed to break the food down. And the process is of an inside-outside movement. So when the patient opens, they move laterally and then they close. And as they close, the inclines of the teeth guide the mandible in and out. And it is the out in which the shearing of the food is broken down. You need on average 30-35 cycles of chewing to break food down properly, but some of us eat fast. I know I can eat quite quickly, so I may be not breaking my food down properly. Cycle in, cycle out. So this looks like this. This is again by Marcel Legal and Roger Yerger. Look at how we open, we move laterally, and we come in, cycle out. And it is a cycle out that does the breaking of the food down. As the food becomes smaller and smaller, the teeth start to touch. That is when we know we are ready to swallow our food. When the teeth start to touch, which is at the end of the chewing cycle. So, in provisionals, we want to get the occlusion right. We have good static contacts, but we want good dynamic contacts. So you can see here the cycle in contacts on my provisional restorations, which we will adjust, and then cycle out. So I know that my shape of teeth is now functioning to break the food down. Because when the patient opens, they move their jaw laterally and then they close. And it's that closing in, the closing pathway, that starts to break the food down. And these are just some references for you that I have learned from. We look at module. This shows us mastication, as does the Teethan. I can also look at the data on the Teethan for mastication as well, for chewing. So when I'm looking at motion data, I'm looking at this level of data, the cycle in, cycle out pathways on my functional movement. If you have good movement like this, this will also indicate good health. And you'll see this good muscle health. You'll see this from the data. So these movements are not something that you think about. They have become part of your central pattern generators. You don't think about it. You just do it. And if the food is hard, you chew a bit harder. But there is a significant correlation between occlusal surface area and the tendency for fewer chewing cycles. So if you're not breaking your food down, you have to chew more. When you have good surface area, you don't have to chew as long. So you're not tiring your muscles out. But there's an effect on this, on sleep quality and parafunction, possible parafunction. Because if you're not getting enough sleep, is this what triggers us to parafunction? Is this what causing muscle disharmony? Because when we look at sleep apnea, or we look at the EEG readings, we want to know about type 1, type 2, and type 3 sleep. And type 3 is the best sleep. We get deep sleep. That's when we heal. That's when the neuro gates open and they flush away the toxins. So stage 3 sleep is what we're looking at. In stage 1 and stage 2, that is when we parafunction. That's a transition between waking and sleeping. We have Levine's papers, and Levine is probably the biggest author on central pattern generators and mastication and sleep, and where the sleep parafunction occurs. But there are some great papers that are now looking at the chewing of your food and your stomach health and sleep. So what we realize is that the best diet is the Mediterranean diet. But if we don't have a good diet, we can actually parafunction more because our gut health is impacted by it. So let's sort of start to finish on a case and looking at how we design a case all the way through using everything that I've talked about: Teethan, module, T-scan. How do we improve the patient's situation? Now, what was the patient's complaint? The patient's main complaint was the fact that he felt that his posterior teeth didn't meet on the right side. He felt his function was impaired, but also he was chipping his anterior teeth more and more. So detailed analysis. This is a digital scan looking at the way he functions, the way he bites. So he's edge to edge. He's a class 3 occlusion. So we start off by collecting the muscle data. And so when we get the muscle data at the start, and this is my pre-op data. So what we see, the POC index, this monitors the difference between muscle activity between left and right side. So it's showing dominance. So if you see here, POC temporalis anterior, so POCTA is temporalis anterior, it's showing normal data. So it's within the normal range, but he has a prevalence on the right side. And I mentioned that his right side don't touch. They're light in contact. So why is the right side muscle activity greater? Well, it's because when the teeth are out of occlusion, the muscle activity increases to try and close the space to bring it into occlusion. So you will always have same side muscle activity when you give them an infra-occluded occlusion. But he didn't say, he said the main activity was in the posterior region. So this actually correlates with what he's saying. His POC index for the masseters, which is for the posterior region, look, it has showed below normal data activity, but it was a right side dominance. And the same with the barycenter, which this is calculated by comparing the activities of both temporalis versus both masseters in a sagittal plane. And you see that the P next to it, this indicates that the masseters are working more, and they will be, because his posterior teeth don't meet, his anterior teeth meet. So everything that he said marries up with what we're finding from the Teethan data. And this is what I love about Teethan. It's simple. I'm not having to overcomplicate things. I just need to understand what POC, both for temporalis and masseter, is, your barycenter, your torsional activity, which is calculated by evaluating the activities of cross muscle pairs in a horizontal plane. And you see here that it shows, again, below normal data. So we're showing a dysfunction here. We're showing muscle inactivity or hyperfunction. But he has a left torsional activity. So that would mean that the left temporalis right masseter is active more. And what's really interesting is his impact. This is the amount of muscle work produced. And look how low his muscle activity is. This is its proportionality of the bite force. So this gives me an overall view. I can look at the pie chart analysis, and you can see that the right masseters are more prevalent, more active out of all the muscles, because he's infraoccluded on the right side. And so there's a disbalance there. Right masseter has a far greater activity than the left temporalis, because this works in the torsional state as well. And what's important is another analysis that we can look at. If you see his ACIM, this is his asymmetry index. Look at how the data is. He's asymmetrical. His right masseter, the full bar, is really active, whereas both temporalis, his right side is a little bit more, his left side is hyperactive. And so you can see that his data at the start shows a problem. But this is only one jigsaw piece. What does the T-scan show? Well, it also correlates with exactly what the Teethan said. It shows a disbalance. So it shows that the anterior force is far greater. Look at where his predominant contacts are. He has only a small proportionality of force on the back teeth. So from a proportionality aspect, when we look at his teeth, this marries up well with what the Teethan told me. And then we look at his function and look at his motion data. If you look at his right side chewing, when I ask him to chew on the right side with chewing gum, he prefers to chew on the left side. So even when there's chewing gum in the right side, I have to correct the frontal plane, you'll see that the chewing motion is preferred to be on the left side. And it is quite a narrow movement. So he has posterior cross bites. Look at his chewing on the left. Because he prefers his left side, his motion on the left side is good. And this is what it looks like. So this is his starting position. As part of his starting position, we're looking at smile analysis. So I like Smile Cloud by Florin Kafar. It's a great tool for me. It makes my life a lot easier, not that expensive because you pay a monthly premium, but it's a good tool for me. And it allows me to design the occlusion as well as the aesthetics. And the one thing that I like about Florin is that he's also linked it with the module. So we're looking also at functional data. So once we have that data, we put it into Exocad and we design. And we design the teeth using the motion data that we have. And then we put him into prototypes. And we have a wax up then done, a printed model wax up, which I just use a stent and composite, and I just transfer it into the mouth. This gives me an idea of the function, the shade. I can actually test everything. I made some adjustments to the lower occlusal plane on the left because the left premolar was high. We added some composite on the lower right to correct the disharmony within the occlusal planes. This is all part of a detailed analysis, and we transfer this into the wax up. Once the wax up is done, you test run it 4 weeks, 8 weeks, whatever you're comfortable with. The literature says minimum 4 weeks, and we transfer him into his final restorations. So now he's into his final restorations. So we need to now check, did we make a difference? So you'll see that his POC temporalis, that was already in the normal range, so that has stayed. It's got a little bit better. It's not majorly different because he didn't have a problem so much that side. His POC mandible, still, it's got better. So we've increased his values. And what we will do is we'll repeat his Teethan data in 1 year, because I've done this 4 weeks after his finals, because we wanted him to adapt. And I wanted to see if we made a real improvement. You can't do it straight away at the time you fit your restorations. You have to wait 4 weeks minimum. So we see that in each of his parameters, some of they're still in the red, but we've improved the numbers. We're getting closer to the normal range. But if you remember, his impact factor was 64%. We're now into 90%. And that is muscle harmony. So we're now achieving muscle harmony. And the green 86 is telling us, as a total cumulative score, we're into a good muscle harmony for our patients. So we've improved things. If we look at his pie chart, we've certainly reduced the masseter activity. It was at 37%. We're dropping it to 32% because now we're giving him more balanced occlusion. He's got more static contacts. So his brain is going to start adapting better and start retraining, and we'll start to see this getting better. I'm confident that we'll get it to equal proportionality. But if you remember the ASYM index, the asymmetry index was 14%. It was above the normal data. We are now into a good symmetrical index for the patient. And this is what I love about Teethan. Keeps it simple for me. You know, I don't want complicated things. I want pictures and I want simple numbers. And numbers that are color coded tells me when I'm wrong. Red tells me warning. Green tells me great. Orange or yellow tells me, okay, we're not into red, but we're in the middle. So, you know, this is one of the tools that we use a lot, and it's even part of my PhD topic at the moment, because it helps a lot. But look at the data now from Teethan. The muscle data has improved. Has the teeth data improved? We've got much more balancing contacts, right and left, 50% equal. Look at the green and red lines. They run really symmetrically. And look at the forces. They're all relatively, there's no red, there's no pink, so there's no heavy forces. This is just him clenching. We have reasonable balance all the way through the arch. What about function data? Have we improved the function of the patient? So now look at his chewing on the left side. On the right side. We've shifted him back so that he's now chewing better on the right side. His left, not too dissimilar from where he was at the start. So left wasn't really a problem to begin with. Left side was quite good, but the right side was really narrow and favored the left side. So have we then rehabilitated our patient? Well, for me, the answer to that question is yes. Because I've measured it. I've improved things for the patient, and I can actually tell the patient that we've improved things. I can show the patient that we've improved things. The patient will tell you they've improved it, but now you can actually believe it. Because when your patient tells you everything is good, doctor, is it because they love their aesthetics? But have you improved the function of the patient? How do you know if you haven't measured it? So it's a short lecture. I didn't want to go on too long because it's a big topic. So these are my contact details.